ourselves, myself, Dr. Dinesh Garg, Dr. Sarvesh Tiwari, and we are, yeah.
Myself, Dr. Deepak Agarwal.
I'm Dr. Neeraj Manchanda.
I'm Dr. Sagar.
So we are waiting for Dr. Avanindra. I think he's stuck up somewhere in other hall. So I have with me Dr. Sarvesh and on the panel Dr. Deepak Agarwal, Dr. Moharana, Karthik, Neeraj, Sagar, and Arindam Chakravarti. So here we are going to debate few of the topics we have in retina and where we all get stuck up. Do we have Apurva? Yeah. Okay. So we'll start with the treatment of PDR, and we have very good speakers here, and for and against. Okay. Can you introduce?
So we have a slight change here. Instead of Dr. Rajiv Raman, we have Dr. Anand Subramaniam. Dr. Anand Subramaniam is a head of department of Vitreoretina in Bacholi Eye Hospital. So he'll be today talking to us about the merits of PRP in PDR. As against him, the person talking will be Mr. Ruhel Saxena, right? If I'm not wrong. Yeah. Rushil Kumar Saxena. So I think with that we'll start with the program.
Yeah.
Okay. Yeah, we'll tell. Okay. With the
For and against Dr. Anurag.
Anurag is there. Okay. So I think over to Dr. Anand Subramaniam. We'll start with you.
Good afternoon, friends. At the onset, I'd like to apologize and state that Dr. Rajiv Raman has been called for judge duties at the Colonel Rangachari Award session, so he's unable to attend this. So all his slides I shall be presenting. So excuse me if I've missed out a few things. So what the topic is treatment for PDR. I'm going to talk on panretinal photocoagulation. I'm for that. So we have all seen such patients, 63-year-old gentleman with PRP done 4 years back with just one more additional session of PRP done. And over the period of years, you have witnessed that the retina becomes like how we can see on the right hand side after 8 to 9 years of PRP. So photocoagulation and PRP for PDR, how does it fit with us? So this is the Diabetic Retinopathy Study Research Group, and these are the numbers. So all these things are familiar to us. We are just reiterating all these things because we want to say that PRP is better. And what about long-term effects? We have numerous studies which says that after many years also, the stability of the eye is very sound. 84% retain visual acuity of 20/40 or better after PRP. What about visual impairment in patients with PDR? So this is SN's own study where Dr. Rajiv Raman has been the chief person in that, where they have seen what we have just said, that it holds true for Indian eyes also. And do we need anything further after doing PRP? So the need for vitreous surgery is also very less after doing a thorough PRP. So PRP is robust. We have been doing it for a long time, and now more than 3 decades have passed after treating patients with PDR. So do we need to change? So change is inevitable. So why do we need to change? For better anatomical outcome, better functional outcome, less adverse effects, less progression of disease, or is it more economical? So we shall discuss all these things one by one. So can anti-VEGF achieve these things? If we could, then maybe we can shift. But let us see Protocol S and Clarity trials. What do they say? Anatomically, protocol S says the percentage is the same. Clarity says anti-VEGF has 30% more NV regression. Functionally, similar visual benefits, similar field loss. Vitreous hemorrhage rates are also similar, but obviously less of macular edema with anti-VEGF. What about progression? Ischemia continues to progress in both. And costs. This was seen in US, but in India we know that we have to do PRP versus anti-VEGFs continuously. Anti-VEGFs are definitely going to be more costly. So the answer after all these things is a resounding no. So should we combine anti-VEGF with PRP? So that there are certain studies which have been completed and ongoing trials where they compare anti-VEGF along with PRP. So what are the concerns? If we say that we are going to inject the patients, almost 60% of the patients after 5 years did not come for follow-up. And the outcomes are quite bad because patient has poor vision with more TRD, more NVIs. So if patient is had a course of PRP and if they miss a few of the injections, still it is tolerable. You don't get such massive regression or flare-ups. So as of today, PRP is the mainstay of management of PDR. It is a time-tested modality. Compared to anti-VEGF, it is safer, good efficacy and economical. Thank you.
Thanks for that talk, Dr. Anand. So next I'll request Dr. Anurag Badani to present his perspective also.
Good afternoon, friends and respected seniors. So I'll be talking in favor of anti-VEGF in proliferative DR, and the question remains that can it replace laser? So is this a right question anyway? So no financial interest to disclose. So PRP, as Dr. Subramaniam has already iterated that it's a gold standard, time tested, many decades, but it does come with a price. And it's practically a destructive procedure and has various side effects like peripheral vision loss, more chances of DME formation in the course of treatment, and loss of contrast sensitivity and night vision. And there are some scenarios in the OPD where we can find that the patient is not able to maintain a sitting posture for long. There are media opacities, a non-dilating pupil. Then doing a good PRP becomes very difficult. And such scenarios are not very uncommon in diabetic clinics. Anti-VEGFs have been revolutionizing our retina practice in the fields of neovascular AMD, DME, ROP, and gradually replacing lasers in some way or the other. And the shift of our aim is to now not just preventing vision loss, but to improving vision quality as well. So this landmark trial is the only trial where both PRP and anti-VEGFs have been compared in high-risk PDRs. And primarily a non-inferiority of the injections have been evaluated for visual acuity outcomes. And as we know, in the ranibizumab group, the injection protocol was to give 4 monthly injections to start with, and then repeat injections if the neovascularization is increasing or worsening. So this is the general outlook in the first 2 years. Eyes with baseline DME required 9 injections median in the first year and another 5 in the second year. But without DME, the eyes required just 7 in the first and 3 in the second year. And largely the protocol S was able to prove that ranibizumab is non-inferior to PRP in terms of visual acuity letter improvement. Also with that, the peripheral visual field loss, need for vitrectomies, and chances of development DME were also far less in the ranibizumab group. And the highlights were that very few eyes in the injection group actually received PRP later during the course of 2 years, and almost half the eyes of PRP group received additional PRP later on, and again half of the eyes in the PRP group also needed injections for DME which developed over the course of treatment. Then came the 5-year outcomes in 2018, which again confirmed that the chances of center involving vision affecting DME was far less in ranibizumab group, as well as the chances of surgery, vitrectomy for retinal detachments. But the mean change in visual acuity and visual field loss difference almost approached each other during the course of 5 years. The reason is because we know that injections have a short lasting effect and they do not increase the perfusion of the retina. But it's possible that the peripheral retina finally gets burnt out, which is a good sign, and that is causing the peripheral field loss over the course of time. But still, it is better than the PRP group. These factors usually hold us back from using anti-VEGFs. Number of injections and follow-up visits are more, but it is a much more comfortable procedure for the patients and takes much less time. Cost effectiveness also can improve with time now, as many insurance companies are recognizing anti-VEGF use in diabetic retinopathies. And to prevent endophthalmitis and cataract, if we follow proper protocols, these are almost avoidable. Systemic adverse events are also known that it's practically very safe, and apart from a little caution in those with history of stroke and coronary artery disease. So just a few examples. This eye patient had advanced PDR in both the eyes. The right eye had DME, that's why we gave injections, and with the course of time even the proliferation reduced significantly and never needed PRP over the course of 3 years. And this is the other eye of the patient. We injected anti-VEGF just for a trial, and it showed that the exudation also reduced, and the peripheral the proliferation also significantly reduced with just one injection, and it maintained like this for the next 3 years, over the 3 years course. So no time for another case. And the final message is that both PRP and anti-VEGFs are good options. We should customize our approach patient specific, and the main thing which we have to judge in clinic is that whether the patient is capable of following up or not. Anti-VEGF is definitely first line if DME is there with PDR, and it also allows immediate use in eyes with media opacities. PRP continues and will definitely continue to build on a 50-year-old history of saving vision, but anti-VEGF should be used to assist PRP and not aim to replace it. Just decrease the need of PRP in course of time. Thank you.
Can you come to the podium, please? And can you rebut what points he has said in favor of anti-VEGF?
I think finally both of us agree that anti-VEGF cannot replace PRP. It can be a supplement to PRP.
Our aim is not to replace PRP. PRP is a time-tested procedure. It cannot be.
I think I think he has agreed he doesn't want to do anti-VEGF treatment. So you are the winner. The message is clear. The message is clear from Anand also and our opponent, who says ki no, I want to do an PRP. And anybody in the audience in favor of anti-VEGF? And not
Anti-VEGF alone.
Anti-VEGF alone and not doing pan-retinal. Vinay, your opinion?
Yeah.
So, yeah.
Apart from these systemic complications of anti-VEGF, what we are discussing and saying
We
is
can
much more commoner as compared, because more than endophthalmitis, I have faced stroke and MI, history of stroke and MI in my injected patients, 1 week, 10 days, or within a month. Many patients. Fortunately, in our side, the patients are not that much aware, so they never blame us about that injection given in the eye leading to a stroke. But as a doctor, we know that there is some role of our anti-VEGF. So we should be little bit cautious, and we should avoid where we can have alternative.
Already the message, the person who is speaking, Anurag,
He's already conceded defeat.
Conceded defeat. So the message is clear. PRP is the treatment of choice in our scenario.
Yeah.
Western scenario is different, but our scenario, PRP.
In our kind of setting where we don't get patients on a regular follow-up, and then cost is a constraint, people travel distances to take treatment, they may not be able to come back again and again. Injections have their own hazard, monthly injections, and then you are poking a needle into the eye. So I think both have a role in their own self, but not for proliferative disease, and PRP remains effective modality for treatment of PDR in our kind of settings. I think
we go to our next debate.
Round of applause for both of them, I think.
We go for the next debate. We go for the first debate, second debate, and that is Octa. And day in and day out, whatever the presentations we are seeing, we are made to feel Octa is necessary for retina practice. So is this a real scenario or not? Whether Octa is necessary, we'll have a debate between Apurva and Rushil.
Thank you for considering me for this debate. It is a very enjoyable talk for me because I absolutely believe that Octa is a must for retina practice. I thought that was a very solemn and sober debate, the first one. So I plan to change that. So I hope nobody gets offended, although my intention is to offend. So this is going to be an image-based debate. My images will speak for themselves. There is no debate here, just scientists and non-scientists, and since the subject is science, the non-scientists don't get to vote. So what's in it for you? It just takes a few extra seconds. It's just there on the machine, same machine, one step extra, no injection, no dye, no retching patient and other patients getting scared about what is happening to him, and there are no contraindications. What can it do? You're going to find lurking membranes. Features of activity also you can find. It lays bare ischemia, inner retinal, outer retinal, choriocapillaris, choroid, and I sincerely think scan ek seek anek. So would you believe that this patient has a CNVM? Let me show you. So this patient, most of us will diagnose as a CSC. This is a unholy mess on the FA because it's a stippled fluorescence, and probably because of CSC you see a descending gravitational tract. But look at this. I found a membrane here, and I would definitely consider anti-VEGF for this patient, which corresponds to this membrane corresponds to a hyper-reflective double layer sign. So look at this wonderful image. I can find a network. I don't need an FA or an ICG. I found this network in a young patient of pachychoroid neovasculopathy. So if you recognize this picture, it's very typical of angioid streaks. These hemorrhages are possible even if there are Brooks membrane ruptures. I did find a beautiful neovascular membrane in a case of angioid streaks. So would you believe that this patient has a CNVM? You can see a perifoveal graying. You seem to think that this is just pre-proliferative mactal. You see this FA, another unholy mess of leakage, masking whatever leakage may be there from a CNV. But look at this image where I've segmented it properly in the subretinal space, and you find this choroidal neovascular membrane. This is another very interesting case. This is a case where we actually found a RAP and a PCV lesion. Let me just show you. This is the hotspot on the ICGA. This is the RP aperture sign, and this is a double layer sign along with a tall peaked PED. And if you see this Octa, it's showing the RAP lesion. And once it comes to this tall peak PED, it's also showing polyps, so many of them. And it was a joy to diagnose a RAP as well as a PCV lesion. So this is another case. My opponent may say polyps are not visible, but I can find polyps on Octa. This is the ICGA, and here you see this beautiful polypoidal lesions corresponding exactly to the ICGA, showing the polyps. So this is a very interesting case of cuticular drusen. I would not expect anybody to find a membrane, but I did because I have Octa. So this is the AF showing a lot of hyper AF material. You can see these vitaliform lesions in the subretinal space. This is starry sky appearance. Where can you see a CNVM? You can't. But I found 3 small membranes which is not masked by FFA or ICGA because of the vitaliform lesions. My Octa can pierce through all that nonsense and find me a membrane. So this I diagnosed as a case of cuticular drusen complicated by acquired vitaliform lesions and CNVMs. So look at this slide. Are you telling me honestly that you will do an ICGA at every visit for this patient when I can show you how nicely this big lesion has resolved with one injection of aflibercept? So what I'm trying to say is, so many times we not only inject unnecessarily in the arm, but we also inject unnecessarily in the eye. So look at this patient. This is a case of amphigenous choroiditis, which I diagnosed on the OCT, no doubt. But look at this big choriocapillaris flow voids, making a diagnosis of choriocapillaritis. It's clinching it. And this shape is exactly like what I found on the ICGA. So for what joy do I need an invasive angiography when I am finding this beautiful flow void on a non-invasive angiography? So if you have money and you're contemplating angiography for your practice, Octa is better than ICG angiography because most of us have FA. So what happens when you know more, when you see more? You know more, you see more, you read more, you write more. And these are my 3 publications in ophthalmology retina based solely on my Octa findings. And you have to agree with me that these are absolutely stunning to look at, and a thing of beauty is a joy forever. Thank you.
We'll take a rebuttal from Dr. Roshil because what Apurva has shown is only macular disease. Are you treating only ARMDs in your...
Sir, you are not my opponent.
So I think she has presented very well, but she has just shown us the good. Now I'll show the bad and the ugly and the real world, what we see in the real world in the high volume clinics. Okay. So thank you all for giving me this opportunity. So like she said, it's a very, Octa is a very quick non-invasive method to detect various vascular complexes in the retina. But to detect that vascular complex, we go through multiple problems, such as we have to rule out multiple artifacts, whether we need to segment these lesions to get a better view, or most importantly, what we are seeing, is that an actual complex, is that a pathology, or is that an artifact? So the reproducibility of these images is a big question. So I'll come to a few artifacts which we see in the recent publications. It has shown that up to 100% of the cases will have at least one artifact, which can be either patient-related, software-related, or operator-related. So the most common artifacts which we see are, one is the loss of contrast. This image in which there was a vitreous opacity in the center, which can erroneously be interpreted as a flow void area. Other artifacts which we commonly see are the projection artifacts, in which the superficial layers are superimposed on the deeper layers, like in this image on the left. On the right, which we see on the top of the PED, there is a neovascular, there is a deep vascular complex which is superimposed on the PED, and it can be erroneously interpreted as a neovascular complex, and we may end up treating this patient. The most troublesome artifact by far is the segmentation artifact, which ironically happens only in diseased eyes or in highly myopic eyes. Like in this eye with the posterior staphyloma, the segmentation is all over the place, and in this eye with the PFT, the inner retinal layers are collapsed, and again the segmentation is all over the place. So various imaging processing softwares and algorithms have been made in literature, but none of them are standardized at present, and they may themselves be have artifacts such as vessel doubling, so it makes it very difficult to read the images. Another limitation is the field of view, which although newer machines are coming up with a wider field of views, they are not of much use clinically. But right now what we have is a very limited field of view, and the wider field of views are associated with loss of image quality, which can make it difficult to interpret. So again, I'll just touch upon the two most common indications in our routine clinics. One is diabetic retinopathy. So Octa does not give us any information on leak. So it is very difficult to make out the leaking microaneurysms, and due to the limited field of view, we are not able to make out the peripheral neovascularizations. Again, segmentation is a big problem in edematous macula, which can be found in up to 50% of patients of PDR, which will lead to segmentation defects and erroneous readings. And our treatment is still guided by structural OCT. In neovascular AMD, I grant you that you will get very, very beautiful images, but what to do with the images after you treat, it becomes very difficult to, there is no standardized definition of an active and an inactive CNVMs. So it will become very difficult for us to know when to treat and when to stop the treatment. Also, again, you'll have significant segmentation and projection artifacts. Certain CNVMs which are deeper, intra-PAD CNVMs or sub-RP CNVMs, you can tend to miss unless you segment manually, which can be a very time-consuming process. So we should be, all the literature you showed, we should be very cautious in applying that literature, because there is a current lack of standardized interpretation protocol, nomenclature and image quality indicators. So various efforts are being made to standardize the various definitions and protocols. This was an article by Spade et al. In 2018 where he bugged us all up that we should get on it and take out some standardized protocols. 5 years later, we are at the same place. There is still no standardization, and therefore we cannot, there is no reproducibility and there is no inter-user agreement. So to conclude, is Octa worth adding to your practice, considering its high cost, limited clinical utility, lack of standardization and inter-user agreement? At present, I would say it appears to be more of a solution looking for a problem rather than being an actual solution to a problem. So maybe someday it will be required in clinical practice, but not today.
Rebuttal from you to Rochelle.
Whatever points he has made are 2 to 3 years old.
This was an article in 2022.
No, but one article you can't show and say this
no,
is
this was
most
total.
Okay, no problem. But yeah, so the projection artifacts, segmentation problems, these are 2-3 years old questions. They have all been sufficiently answered by projection resolving and segmentation, which takes only 10 seconds if you make a section of 15-20 microns from the ILM to the Brooks membrane. So I think apart from having any machine, you also need a person behind the machine who can interpret images. So if you give some high-end imaging machine to somebody who is not interested in imaging, they will not find anything on angiography, invasive or non-invasive.
Very true. The person behind is important, and you have to see in fast, or you have to move the sections. Yes. I'll ask Deepak and then Neeraj to give their comments whether OCT A is mandatory for the practice or not. And then we'll take one person from the audience. I'll ask Dr. Guru Prasad to comment after that. No, we'll have an independent opinion.
Every new technology has its pros and cons. Octa has been there for quite some time now, and we are learning on it. Maybe over a few years, we will learn more. The only problem is the availability remains an issue. It's not available at our center to be precise, and then again the cost benefit is a ratio is a thing. So to be very frank, I don't have much experience with Octa.
I will add to this, Dr. Abuva, you are right, and like Avanindra said, that you have shown only the central lesions, AMD lesions only. So there are other indications of angiography also. So I would say that Octa is an add-on at present, and as he has also said,
with my bare eyes
so you can see that, but because there are certain other problems in the retina also that may need an angiography, the leakages and all those things, the effect of treatment of laser, so that all that may not be very well picked up at present. So maybe future is there, but definitely I think these are both supplement to each other. If you have both technologies, that is better than having either one of them. So
can I speak one?
Yeah.
The best application of Octa is in pachychoroid disease with CNVM. You cannot diagnose CNVM in such cases with OCT where you think it's a CSR, and also FFA and ICG, as she showed, just shows a stippled hyperfluorescence. You do not get the CNVM leak. The moment you do Octa, that amazing vascular network is crystal clear, and you don't need to think anymore. You have to inject anti-VEGFs there. So this is the best possible application of Octa at present. And many a times when we pick up a CNVM on OCT, instead of doing an FFA, most of us do a baseline FFA, used to do a baseline FFA. So instead of doing a baseline FFA, if you have a Octa, you can take a Octa image, show the CNVM network and start the treatment without injecting the dye. But yeah, it's a very costly machine, so it needs a few more years, lowering of costs, and then it is a technology which will continue.
We will take, is it mandatory for your practice and then Dr. Dr. Gurup sir. And then one mic to Dr. Dinesh Sarvesh, please, here.
So I think both made their points very well. These debates, I tell you, are to get the best out of each speaker, to get the pros and cons of each technique that they're talking about. It is not about fighting or arguing. So I think we have to collate the two and take it is up to the audience to extract the best out of the argument that is going on, or the debate that is going on, so-called debate, which is not really a debate according to me. It is a scientific knowledge outpouring which we have to get the gist out of it. So, but then yes, there are certain disadvantages of Octa in terms of the field of capturing that we have. It's just about 6x6. Even if you stitch, so-called stitching that is described by the manufacturers, I think it is not so easy. The posterior pole, yes, for ARMD it's a wonderful tool. Angiography has its own plus points in the peripheral diseases. So that way I think we have to, get the best out of all these.
Dr. Dinesh, please. Now with wider field octas are available with 12 by 12 and 16 by 16. I think with 12 by 12 montage which will come, I think it will become more useful.
If we stuck to what we have, then we would be still in the Stone Age. We would be using the wheel which was made of stone and traveling by bullock cart. The fact is that every new thing that comes needs refinement, and refinements are going on in Octa to a level that there are certain subtle diseases, as Arindam just mentioned, where we can actually say this does a better job. We also have a situation which I think you were trying to mention. Wide field Octa can pick up neovascularization, areas of capillary non-perfusion in cases of diabetic retinopathy. So so it's not something confined to the macula. We are moving from the center to the periphery. Yes, it's an expensive machine like any others. There was a time when there were hardly any hotels. We could not have afforded this kind of conference. There was a time when the conferences were done in Maidans. Today there are so many options, so the cost comes down, and we expect the cost will come down. But we need a few early adopters. The early adopters are those who will be at that cutting edge to pick out, and they will also be wrong many times. They will find what they find will turn out to be wrong with the passage of time, but they will also find a lot of new things. And today OCT-A is something which is mandatory if you are in a teaching institution which wants to stay on a cutting edge. If you want to do a high volume surgery where you just want to deliver mass cheap surgery, you can do with OCT.
Is it still a research tool? I think
I didn't say it's a research tool. I said if you're at the cutting edge, then you want to see how to refine its use. But if you're not at that cutting edge, because this takes time, yes. As Avanindra was saying, manual cutting, manual segmentation is not so simple. That she was trying to put it a little less than it is. It is, if you want to do a proper manual segmentation, she needs to do it, not her technician. So there's a difference, and she is very busy.
Actually, OCT, many a times we detect lesions once we sit on the machine and we do a manual in-fast segmentation. And what the machine shows at ILM, that does not give any information. Actually, you have to go to what Apurva shows. Either you have to do a video in fast imaging, or you have to manually change the area. You will get a lot of information. And in those situations, you are also able to get away with projection artifacts.
Thank you
very much.
I think we are short of time, and let's go to another debate. Very interesting, and for everybody in ophthalmology, managing end ophthalmitis with vision less than finger counting, and intravitreal antibiotics. For it, Dr. Sarvesh Tiwari, and against it is Dr. S.P. Tiwari, who will be speaking about early vitrectomy. Dr. Sarvesh, please.
Sure. Thank you, sir. So today I'll be talking about how to manage endophthalmitis where the vision is better than PL, to be frank, and I'll be focusing more on the need of intravitreal and to avoid core vitrectomy. So my points in the favor would be, just to explain, post-operative end-off is defined as infection within 6 weeks of any invasive procedure of the eye. Before I proceed with the talk, I would like to present some cases. This is a case 1 presented with finger counting 2-meter vision. As you can see, with moderate vitritis. After 3 weeks and 3 intravitreal antibiotic injections, the vision improved by 6/36. This is the second case in which the patient presented with vision PL plus dense vitreous pupillary membrane around 1 millimeter hypopyon. The patient received 5 serial intravitreal antibiotic injections followed by vitrectomy later on. After 1 month, the vision improved to 6/60 and the vitritis nearly resolved. This is the case 3, vision hand movements close to face. 2 intravitreal injections were given. After 2 months, the vision improved to 6/18, and after 3 months, the vision improved to 6/9. This is the fourth case, patient presented with vision 6/60, received 3 serial intravitreal antibiotic injections. After 2 weeks, patient's vision improved to 6/12. So the rationale of showing you these 4 cases is that, as you can see, except the second case, all the remaining 3 cases had vision somewhere in the range of hand movement to 6/60 or something. And we managed to successfully treat these patients only with intravitreal antibiotics. Depending on the severity, the number varied. Only in the case where the vision was as bad as PL+, that was the only case where the intravitreal injections were followed by vitrectomy later on. So the protocol visually which we followed is, when the patient presents to us, we take an AC tap, and if the AC is very flat and all, then we prefer to take a vitreous biopsy. The tap is sent for culture, KOH mount and gram staining. At that point, when the AC tap is taken, we give an intravitreal antibiotic of vancomycin and ceftazidime, as is the norm. Where we suspect fungal infection, we give only intravitreal voriconazole. Except in where we suspecting a fungal cause, we also give intravitreal steroids along with the antibiotics. We have a protocol of giving systemic antibiotics also to the patient. We preferably want to admit the patient for 5 days, where we give intravenous ceftazidime and gentamicin injections, which is later followed by oral course of steroids by 1 milligram per kilogram body weight after the hypopyon and the vitritis has resolved to a great extent. So our protocol in which we refer early vitrectomy in vision where it is vision is better than PL+. Why so? The points in our protocol favors are, first, when the patient presents to you with an acute end-off, the view of the media is hazy due to corneal edema and anterior chamber exudates. Now, doing a core vitrectomy in such an eye is essentially a blind procedure. So there are high chances of instrument touch both to the iris as well as to the retina behind. The infected retina is always very friable, and as it is ischemic, so more chances of iatrogenic breaks. Inflamed eye, so more chances of intraoperative and postoperative hypotony, which can cause suprachoroidal hemorrhages, etc. It's a painful procedure owing to severe inflammation, and it also causes psychological trauma to the patient as it involves a second surgery soon after. So just to brush over, our approach is, if the vision is more than or equal to hand movement, we just give serial intravitreal injections on alternate days till hypopyon resolves, which is later followed by a course of systemic steroids, which is tapered gradually. If the vision is PL+, we initially give 2 intravitreal antibiotics alternately, followed by systemic steroids and core vitrectomy if needed. So just to give you a short statistics, in our institute, over a period of 5 years, we had 57 cases of end-off, in which 41 got cured only with intravits, 10 required intravits followed by vitrectomy, and only 6 cases required vitrectomy, which was followed by intravits. The Moorfield study, which was conducted between 2013 to 18, also showed that 33 patients which underwent core vitrectomy, 8 developed RDs, 5 had iatrogenic breaks, 5 required resurgery with tamponade, 3 had choroidal effusions, while 1 each had macular hole, 1 had to be eviscerated, and 1 had to be enucleated. So in the Moorfield study, all 27 exogenous endophthalmic relatives received preoperative intravitreal antibiotics, and the mean duration between injection and surgery was 8 days. So there is a no hurry core vitrectomy approach we follow, the benefits being organization and consolidation of the vitreous exudates. The evolution of PVD subsequently helps in the core vit, less pain to the patient as the eye inflammation subsides a bit following serial intravitreal antibiotic injections. So my take on this, in less severe cases of endophthalmitis can be successfully managed by intravitreal and systemic antibiotics and steroids. Core vitrectomy should be reserved only for severe cases. Over to you, sir.
Early vitrectomy. Dr. S.P. Tiwari, please.
Good afternoon, sir. First of all, thank you all for inviting me here for this wonderful debate. My slides, please. Yeah. So I think this debate is, this can be a debate if majority of people are anterior segment surgeon who cannot do vitrectomy. I think if it is a debate of vitreoretinal surgeons, then definitely there is no choice rather than going for early vitrectomy. So why? Suppose a thief come inside your house, you have just neutralized him, and suppose everything is all right, you can have a just peaceful mind and peaceful sleep, you are sleeping. But what if it is not, like developing lot of complications and cornea is becoming hazy, the endophthalmitis is progressing? Because not all cases can respond to intravitreal antibiotic. Those simpler cases where the organism is not that virulent, they are just simple, then you can wait and the eye will be quite less painful, and then you can go for a late vitrectomy. But what happens if the organism is very, very virulent? So what we need to do? We need to kill them all before they kill the eye. So early vitrectomy is the answer in cases of all those severe endophthalmitis, or even for less severe, because if you have cleared the vitreous cavity which is keeping all those organisms, then that is a better option for treating endophthalmitis. Yes, intravitreal antibiotic is the initial management, but how do we choose that antibiotic? You need to have some sample, you need to do microbiological study, and then you find out which antibiotic is working better. How do we get that sample? Suppose we have done ACTAP, then it's good. Suppose we are taking blindly that vitreous tap and aspirating the fluid in uncut vitreous, that also causes a lot of problem, and it can lead to traction, retinal breaks, and later on retinal detachment. So in IOAB, it is always empirical. We are confused whether we are giving antibiotic, that is vancomycin, ceftazidime, or piperacillin, or whatever, amikacin, or voriconazole. Then it doesn't reduce the infection load, and the proper sample cannot be taken unless we do go inside and do a vitrectomy. Endophthalmitis is a devastating complication. It can be understood by the agony of the operating surgeon who ended up with a endophthalmitis rather than promising a very good vision to any cataract patient or whatever, any vision saving surgery. So lot of vision saving, eye saving, and medical legal questions to be answered. Can we afford to offer suboptimal treatment in modern era of vitrectomy? That is a question need to be answered. IOAB followed by conservative treatment or vitrectomy was a treatment of past, but when vitrectomy machines were primitive, viewing systems were not good, trained vitreoretinal surgeons or vitreoretinal surgical setups were not available readily, and complications associated with vitrectomy were high. Definitely that was a treatment of choice. But now a lot of studies have come out, and they've shown that actually the results of vitrectomy doing early rather than giving injections and waiting is better in cases of doing vitrectomy. These all lot of studies showing that definitely we should go for vitrectomy early, even in cases of less severe endophthalmitis. Why? Because nowadays machines are accurate, expert surgeons are available in all tier 2, tier 3 city, even district cities also, good machines, microscope, viewing system, micro-incision vitrectomy surgery. Sometimes we take 23 gauge needle to aspirate the vitreous, but we can go inside with 27 gauge and cut the vitreous and remove the culprit directly, and that is much safer than taking a 23 gauge tap and taking out vitreous. So why to wait for microbe to damage more till we remove them out? I would end my talk with a question that would we inject and wait for response rather than going for a vitrectomy if any of our own family member is the patient? Post-op endophthalmitis, vision is count finger or 360, 660. There is endophthalmitis, we are having a good surgeon, vitreoretinal surgeon and a very good machine, microscope. Would we inject and wait, or we would go for direct vitrectomy? So that is the end of my talk, and rest is for the panel.
Thank
Your
you.
rebuttal, Sarvesh.
Pardon, sir?
Your rebuttal. You said ki I don't want to do.
Your question, the last question which you asked, I would say yes. I would still inject intravitreal and wait. If I don't have a view of the fundus, if I won't risk doing a blind vitrectomy, and as I insisted before, provided the vision is not very bad. If as a second case, if the picture is that bad, then definitely I go with you.
What is blind vitrectomy?
Pardon, sir?
What is blind vitrectomy?
That is when you you can't see the fundus. You have corneal edema, you have membrane in the pupillary areas.
Half our vitrectomies are blind only, vitreous only.
The question here is, what do you do in moderate cases where you can see the fundus? And this hazy view, then what will you do? Still operate immediately or give an intravit?
Give an intravit for me, still.
No,
I think both
Dr.
the speakers.
Dinesh, your comments final.
I think both the speakers, they have separated their field of expertise very nicely. Means to begin with, he told that it is for severe cases, and in your last slide you told that I am only for the milder ones. So basically, you both are not fighting and debating. But yes, for cases which are very mild, you can have that approach. But the issue is, what is the amount of vitreous involvement? Means many a time the vision is low. You just can't keep that as a single parameter deciding whether you want to go ahead with a vitrectomy or not. Many a times the posterior segment involvement is very less, but the patient has a dense pupillary membrane. Then these patients, they respond to your line of conservative approach very nicely. The membrane contracts very nicely, and 1 or 2 injection that will do the job for you. But certainly not in my opinion for severe cases where you have denser vitreous exudates and posterior segment involvement.
Dr. Dinesh, final comment.
Yeah, I think what I do is I inject once and see the response, and if the things are improving, we might repeat injection, but most of the times I don't repeat injection. And if the things are not improving or worsening, go ahead with vitrectomy. Of course, interval vitrectomy, or as you said, doing vitrectomy later on, is always an option for patients where they don't respond well, or they still have some exudates in the vitreous. But if the ultrasound is not showing PVD or a clear vitreous, then of course we have to go in, and if there are some choroidals developing or some retinal lesions, then of course early vitrectomy would be answer.
Sir, one question to the panelist also. Does core vitrectomy exist, or we have to remove the posterior hyaloid? I'll ask SP.
I think
according to me,
we have
the
to.
view is not good, sir, then we can go for limited core vitrectomy, and then later on, if everything is settled and the eye is quiet, view is better, we can go again and
according
remove.
to me, there's nothing like
Yeah,
core vitrectomy.
yeah.
But
You
sir,
have to do
sir,
remove the
suppose
posterior.
if the vitreous and the cornea is not that good, like recently I operated post ICL case, and there was a lot of exudate in the anterior chamber, everything was hazy. I was not seeing anything, so I just cleaned the anterior chamber, did limited core vitrectomy. Once everything was settled and there was PVD, again I went in and did.
So
That's a
what you are
partial
doing.
vitrectomy.
That you are doing to decrease the load, and then so that
And that was
intravitreal,
culture proven pseudomonas, but still we
that's
got.
what you are doing. You are decreasing the load and then giving antibiotic. So the final results of vitrectomy come once you remove the posterior hyaloid.
Yes,
Of
sir,
course.
yes, sir, that is true. Actually, I would share. I
you
would
come
share
on.
my experience of managing cluster endophthalmitis. Two similar situation in Bihar. We had a cluster endophthalmitis of 22 cases from a charitable institute. All were pseudomonas endophthalmitis. They sent all cases with a bus, and I operated whole night for all 22 cases. We did not remove any of the eye, and there was no media coverage. Everything was cooled down, and nobody known that such a big incidents happened. Just suddenly after another year in a different institute, they had similar episode of 25 cases, pseudomonas endophthalmitis. They managed locally, waited, and they sent after 3 days. When they came to me, all the eyes were melted except one eye. There was no scope of giving even intravitreal antibiotic. Everything was melt, and all the eye had to be removed. And that hospital is now closed. There is court inquiry, there is legislative assembly inquiry, civil surgeon inquiry. Even they are sending a lot of letters to me. Just I saw the cases and just advised that what can be done, and that made a difference between taking quick decision and delaying the decision. So I think in endophthalmitis we should take with a any quick decision is better for patient.
I would like to add, for in case of pseudomonas, you don't have much of a choice there. You don't.
I
there's
just
nothing
want
to
to
debate
know
in
how did you do
pseudomonas.
22 vitrectomies in one night? That's all.
Sir,
all new packs, all new packs.
No, not even a new pack.
No, sir.
How many
That is
hands
just one
did you
pack.
use?
You can't do with the same cluster. What is the meaning of changing the cutter, light pipe, a
How
trocar?
many
and
hands
cannula?
did you have?
Just alone. I did all the cases just alone, sir.
That's
in a
great.
normal
I
days
think
also.
hands
sometime-
off to.
Yeah.
Let's move on to the next debate. ERM.
Yeah. Yeah, one comment from
With
Dr.
or without ILM peeling?
You can give
Okay.
one comment.
We have Anand Subramaniam
Sir,
for ILM peel.
there was one comment regarding the previous talk. Actually, in the previous talk, one point was to do with or without silicone oil. That was a part of the debate. I think, sir, it's also about inducing a PVD, doing a complete vitrectomy. I think the retina is so much friable. If we're doing a complete vitrectomy, then we should go for a silicone oil implantation. Otherwise, doing a core vitrectomy is good enough.
Yes.
Good afternoon again. So
Dr. Anand.
the debate is ILM. I'm going to peel off all ILM. So, but this debate is restricted to only idiopathic ERMs. I want to clarify before my esteemed opponent gets other things into the fray. And it is not for other types of ERM. It's not for macular hole, rhegmatogenous or TRDs. So, if you're saying why peel, I'm asking you why not peel. So, if you're not going to peel, you don't want to peel because you're going to cause complications. If we are going to have these complications, we don't want to peel. So what are the early and late inner retinal changes? These changes which I mentioned do occur after peeling any epiretinal membrane or any ILM, but these are temporary. The swelling of the optic nerve fiber layer, it happens, but then it disappears. There is dissociation of those nerve fiber layers, but they do not cause any visual changes. If there is CME, they have found out that the CME occurs with epiretinal membrane is the same as if you peel the ILM also. And metamorphopsia, the scale also says it's not going to be different if I peel the ILM. So this is the case which I did last week, and this I was very meticulously trying not to peel the ILM so that I can see how it is, so that we can present it in this debate. So I'm trying very slowly to remove it with the ILM forceps. The first staining is with tryphan blue. So this is most of the macular puckers that we see are like this. So it's a dense pucker, it's attached to the retina quite densely. I'm trying to remove it slowly. So it comes off with a little bit of bleeding. So now I will stain it with BBG again, just to see how the residual ILM which I have tried not to peel is. So this is how the residual ILM is after trying not to peel it. So can we not peel the ILM? If I wanted to not peel, I am just trying to do this. I did not want to peel the ILM. 55% had spontaneously gone, and 40 had, and the other 40 had which has damaged ILM. So why not remove it? So we remove it because the recurrences rate are going to be very less when you remove the ILM, and has been proven with many studies also. So whatever said and done, ILM removal is traumatic. I agree to that. You have to be judicious. You have to be meticulous. So if we are vitreoretinal surgeons, we spend a lot of time in the retina, and you say that I'm going to remove the ERM and leave such a crumpled ILM behind. I don't agree to that. But there's still a lot to learn about Mueller's cells. We need to know about that and then take it forward. Thank you.
I'll take it from the very last slide, what Dr. Anand has said about Mueller cells and about the damage what he has caused with the ILM peeling. So this is one, Anira bhai. So my journey started with this patient. This patient was a patient of macular hole. This I operated somewhere in 2015, a very high IQ patient, recovered with 6/6 vision from finger count, and I was also amazed. After 1 year, he started complaining of blurring of vision. Although the vision was 6/6 part, we did all the investigation why is this patient is complaining of blurring of vision, and what we saw, we did all the investigation. You can see this GCC layer here. This is on 2017. You can see this red area here. There is a loss of GCC. 2018, it has increased. So you must not have seen such a long follow-up, and this patient is still following till 2022, and this GCC layer damage has increased over a period of time. Now, visual field defects, there are slight visual field defects here. You can see there are two black dots here. Another patient here operated for macular hole here. Initially in 2018, you can see type 1 closure. 2018, there is no GCC loss. But the moment you come here in 2019, you can see a ganglion cell loss here. Okay, this is sequential pictures. I'm not talking about short-term gains. I'm talking about long-term gains. This is another patient of macular hole, type 1 closure. And you can see the huge red area here, a huge area of ganglion cell loss. Now, this is one of the patient of vitreomacular traction. We have not peeled internal limiting membrane. And you can see 2018 and 2019 picture. Not peeling ILM, there is no loss in ganglion cell. So this confirms my hypothesis. Yes, you don't have to peel ILM. Now, what is ILM? ILM is basically a basement membrane of Mueller or glial cells. Its removal may affect Mueller or glial cell function and surrounding neural tissue. This is one of the articles published in November 2021, and 47 patients were taken into this study. 17 patients developed post-operatively visual field defect, indicating a significant association between ILM peeling and visual field defect. The observer also observed thinning of the ganglion cell layer, what I am telling you, what I have observed also, and this paper also shows. Thinning of ganglion cell layers temporal to the fovea and retinal nerve fiber layer in patients with ILM peeling. Both findings may prompt surgeons to reconsider performing ILM peels for idiopathic epiretinal membranes. Now, this is one of the meta-analysis that is published in 2021. The meta-analysis what you were talking about recurrence was 2017. Okay, this is 2021 with the same author. The study showed that ILM peeling did not significantly improve post-operative visual outcome or decrease recurrence, but results in thicker macular thickness, indicating that it is inessential for idiopathic epiretinal membrane for the ILM to be peeled in this kind of situation. So I conclude ILM peeling should not be done in cases of idiopathic epiretinal membrane.
Thank you for the talk, sir. Sir, just I had a question for you. As you just pointed out that it is not necessary to peel the ILM, it's more of traumatic. Do you usually check after you have peeled it do you stain it and confirm whether the ILM is still intact, sir?
No, that see many situations, if I feel ki ILM has not come in toto and the ERM has not come in toto, I go ahead and stain either with a trypan blue or with an BBG dye, and I can find the remnants and then I peel those.
Okay. So in case, sir, if you have to follow your approach, how do we ensure that the ILM stays?
See, there are certain situations where ILM and the epiretinal membrane is densely adherent. In those situations, you are not able to get an edge, and you have to create an edge in the ILM. But if you have a choice, you don't have to. There is a choice between ERM and to peel ILM. If your ERM has come in toto, then don't go ahead and do an ILM peeling.
Your take on it, sir?
Sir, again, I would like to say that according to my first slide, I said that we are talking about only idiopathic ERM.
These were idiopathic
sir, you are
IRM.
comparing apples with oranges.
No.
You showed us all macular holes.
No, the macular holes. See, we have to show patients with macular hole because we are doing mandatory ILM peeling in those kind of patients.
See, mandatory peeling in macular holes is causing visual field defects. So that is what is being shown here. When you are doing it in ERM, it is not mandatory to remove the ILM always.
No, so when we have moth-eaten ILMs and when the ILM is going to come with the ERMs, so I would say that you remove the rest of the ILM and make it a clean surgery.
Yeah, that's true.
So I think due to paucity of time, we'll switch over to the next talk. I would welcome Dr. Dinesh Garg, sir, to talk on.
I think he will talk for.
Dr. Avanindra is going to talk for Dr. Saurabh Arora. He couldn't make it, unfortunately.
So my talk is a video of about 3 minutes. So this is how it looks like in the post-operative period. If you can see those small 2 dimples of the claws on the iris. So volume. So this is as we deal with the nucleus drops and other things, and this is a SICS case where we are putting a iris claw lens. So this is a special kind of a PMMA lens where there are 2 haptics with the claws, and this was initially being put into the anterior chamber by the world famous Dr. Daljit Singh. Nowadays we are doing a retrofixation of this. This little part is a blind one, but it can be easily done, and once mastered, it is not very difficult to achieve. You hold the lens from the center with the forceps which is vertically oriented, and then just tuck the claws and check it on both sides, and that's the end of the surgery, and it beautifully holds there. Can you put the volume, please? Similarly, there is another video. चला दो इसको. So this is another one, and you just push the lens through the already made scleral tunnel, and is brought in position of horizontal location of claws. A special IOL holding forceps for posterior fixation is used to hold the lens, and it is tucked in position. Similar maneuver is done on the other side. So you just hold the lens from the center, lens with the claw at the posterior fixation, and tucked it with the help of a IOL is checked for fixation and the IOL forceps is removed. That's the end of the surgery. So these are the couple of special instruments which we need. Most of the times nowadays I use this Clayman IOL forceps, which is L type and T type, and this will go vertically and hold the lens. Thank you.
Thank you, Dr. Dinesh. I think Dr. Dinesh didn't show, being a retinal surgeon, he didn't do vitrectomy in any of the cases. But we
have already completed vitrectomy in all these cases, because I removed the drop IOL.
Okay, these were the special situations, but routinely he does not do. And if you don't take care of vitreous, then I think our basic purpose of secondary IOLs is lost. In our technique, it's mandatory to do vitrectomy and take care of the vitreous, which is the biggest culprit in secondary IOLs or situations of aphakia, PCR, and no PC. My choice is scleral fixated IOL. So these were okay cases. If you have situations like this where there is an iris chafing, the pupil is not constricting, because it's mandatory to have a small pupil, or you generally constrict the pupil with pilocarpine in iris fixated lens. If you have an SI or dilated pupil, you can't perform this procedure. Or if you have an iridodialysis or an iridia also, there is no iris, where will you fix the lens? So in situations like this, the best choice is scleral fixated IOL. And either you can do a Yamanas, or you can do an tuck technique, or you can do an glued scleral fixated IOL. The problem with iris claw lenses is it's a poor dilatation. Dr. Dinesh is a retina surgeon, and he doesn't realizes the importance of dilatation. And he says, I'll keep my pupil constricted. If something happens, like detachment, what will he do? The optics is so small, it's 5.5 millimeter optic. He won't be able to do a good vitrectomy. No peripheral base dissection. Patient will come again with a detachment. And the biggest problem doing a retinal surgery with this lens is, the moment you do a fluid air exchange, it rotates, it dances like this. But it doesn't happen in scleral fixated lens. There is an ovulation, there is an iris shaping, and iris, there's a lot of pseudo-phacodonosis. So if you see the lens, it's dancing in the anterior segment. If it is dancing in the anterior segment, you will have a lot of complication like endothelial damage, and that was one of the reasons why Dr. Daljit Singh lens was discontinued. And since you are putting the lens on the iris, there will be a lot of pigment dispersion, secondary glaucoma. So doing this technique, he's inviting all complications. So what is desirable is insert the IOL where the lens is, normal lens is there, that is in the posterior segment, and all of his IOLs, what he's doing, he's implanting into the bag or sulcus. So that is the best position, and you have to do an scleral fixated lens. So this technique involves good vitrectomy, good post-operative vision. And other problem is, see, one of this patient, this is an AC IOL, very good surgery done 10 years back. Patient had 6/6 vision. One eye patient came with, after 11 years, he came with pseudophakic bullous keratopathy. We did the specular microscopy in the other eye. The count was 1000 only. After 10 years of good surgery, what you are showing is a short-term results. After 10 years of surgery, patient realizes because of the IOL, he is at the verge of blindness, and both the eyes requires PK with removal of IOL. So other procedures like this patient has an absorbed cataract. This is a child, and you can see we have done a scleral fixated IOL. You can see an haptic, and this patient is maintaining 6/18 vision with such a bad eye. And DSEC procedure, you can't do anything corneal procedures with iris fixated lens. You can see this, I have done a DSEC with this glued IOL, and you can see a good cornea, clear cornea, and the vision improved to 6/9 and still persisting with 6/9, and you can't do anything like this with iris claw lenses. Another patient, you can see a valve here, AC IOL. So what we did was remove this valve, did an scleral fixated IOL, and did it PK. This patient is still maintaining 6/24 vision. So to conclude, difficult roads often lead to beautiful destination. Slow and steady wins the race. So although it's a slightly difficult procedure, but long-term results are good. So I recommend all of you to go for an SF-IOL. It's easy to combine with various corneal procedures, and if you see the sutures versus scleral fixated results, almost it is same, and the problems like ovulation of pupil are less. So you can choose either of the way. You can choose to go like this way, eat ice cream, and you can make a mess, or you can go with a difficult way and have a clean surgery and good long-term results. Thank you very much, sir.
Yeah, I think first of all, I must thank Dr. Avanindra, and then I think you should go to a island, Paradise Island, because what mind doesn't know, eyes don't see. He could not see 3 pars plana ports in any of my eyes, the ones which I operated, and he feels I have not done vitrectomy for those. He is showing you angle fixated IOLs, and he is saying it causes bullous keratopathy. I am telling him it is gone into the posterior chamber, and he says anterior chamber IOLs cause bullous keratopathy. I think you are living in a fool's paradise.
But
the thing is, we are doing it in difficult cases where there is no posterior capsule, where I am not saying this is for 100% of cases. I am not stopping my phacos and started doing iris claw lenses. You are talking about Dr. Daljit Singh, who was putting iris claw lenses in all cases and not doing phacos. So what I am suggesting you is, come to me for a day, have a good night's sleep, and come to my OT in the morning. I'll show you how to do a good iris claw lens and have a good result.
No.
Otherwise, I thought you are practicing in Delhi, a big national capital of a country, but probably you are living in a fool's paradise.
So the basic problem
The island where knowledge is limited. You have to open your eyes to the new world. And this is something which is easily doable for any veterinary surgeon like you.
So the basic,
please open your eyes, sir.
The basic problem is you are showing short term and the easiness of surgery. That's what I have commented. Ki easiness and short term results does not end up into long term results.
These pupils do dilate, and Dr. Daljit Singh always show dilated pupils after this. Probably you have never seen my post-ops.
For that I'll have to come, and you have to publish long-term data. Yes.
Yeah, that's true. So I think we end the debate with this.
Let me just practicing in a part of the country where we have bulk surgeries being done by the anterior segment surgeons, where they are placing the iris claw lenses, multiple iris claw lenses, where they're doing 30 to 40 surgeries in a day, and some of them get wrong and they place iris claw lenses. And to be very frank, sir, removing such an iris claw lens is very difficult. if something goes wrong. Means for a VR surgeon.
No, there is no complication here. Then why do you remove it?
No, sir. If there is a complication, say one
No,
of the.
I'm not saying that there is no complication. Any surgeon who says there is no complication means he is not doing surgeries.
Yes, sir. And
So the tucks get removed,
Yes, sir.
can get dislodged, and they can fall into the.
Yes,
but
sir.
they can again be reposited, and it can very easily be removed. The only thing is you have to remove that iris from the claw.
Okay.
Okay, the same hook or the rod with which you have tucked the iris will bring it out.
So one of the cases showed marked uveitis with raised IOP.
So the reason must be, as Dr. Avanindra said, that they have not done some complete vitrectomy, and there
That
might be some
because it was
residual lens matter staying inside, because uveitis and other things, they occur more with the angle supported lenses. There is no touch with the angle in these situations.
I totally agree. When you are doing a vitreoretinal surgery, if you have an iris claw lens, it's very difficult to do surgeries in these kind. I've tried to expand. I also had the same problem what
Yes,
you are saying. The main problem what it comes is the air comes into the anterior chamber, and the iris keeps on rotating, the IOL keeps on rotating. Then silicone oil comes into the anterior chamber. That's also one of the problems. But these are few situations, not all situations. I think the incidence of detachment is not more than 2 to 3% in these kind of cases. So if I have an iris claw lens, I'll prefer, I have done 2 or 3 cases with iris claw. The problems what I faced was similar, and I tried to remove it, but it was difficult maneuvering that, and doing vitreoretinal surgery.
I would agree with that.
Vitreoretinal surgery is a difficult situation.
So I think the similar situations do arise with the SFIULs also, because there is no demarcation between anterior and posterior chamber. The air comes in front even in those cases. Any case of posterior capsule rupture, the air does come.
What I do is I do a PFCL silicone direct exchange in these kind of situations.
Yeah, that's
so I don't go for an air. I go for a PFCL silicone oil exchange.
Yeah.
And if you have
except for GRTs, I don't do that. I do air exchange. But normally what I do is I just use a soft tip and remove air behind the IOL.
Yeah, we have to conclude this session. Thanks to all the speakers for their excellent debates. The next session is, so the people are already waiting for the next session. So
thanks a lot. Thank you.
Thank you everybody. Thank you.